Today I will present to you an eye care model that was used to revitalize the eye units of 10 government district hospitals in Bangladesh. Okay, so just a bit of background about myself. My name is Zara Khair. I have completed my Masters in Development Studies from Raqqa University in Bangladesh. And my key interest areas are public health and research. I am also very passionate about gender mainstreaming and the health projects that I design and develop. And at this point, I would also like to mention that I am working for the Fred Hollows Foundation, which is an Australian international NGO, for the last 4+ years. And currently, I'm working as the program coordinator in the programs team. The Fred Hollows Foundation, or the foundation, is an Australian INGO working since 1992 to eliminate avoidable blindness in the world. Currently, it's operating in over 20+ countries in the world, and in Bangladesh, it is working in close partnership with the government of Bangladesh since 2008 only. And at this point, I just want to mention that my participation in today's conference is self-funded because because of my keen interest in public health. I've come to join this conference, and as such, I take a neutral stand in today's presentation. So, I will be going over the introduction, background, project interventions. I will be talking about one of the projects that the foundation in Bangladesh has implemented. I have used data from the project data, which is also consistent with the National Institute of Ophthalmology and Hospital, the reports. Then I will go quickly over the results, discussion, conclusion, and then we can take question answers. And I would like to thank the Fred Hollows Foundation for giving me access to vast records and data. So a bit of introduction there. The public health sector in Bangladesh is faced with many challenges, but it is the only hope for the rural mass. Eye healthcare services are supposed to be provided by the government district hospitals, by all 64 government district hospitals in our country, which is located in each district, so that they are accessible and affordable by the rural poor or the rural communities. Unfortunately, though, this is not always the case. For example, currently about 26 of the 64 eye units are conducting cataract surgeries only. I think I'm highlighting cataract here because it is one of the priority diseases in eye care sector. In Bangladesh, it accounts for about 80% of all blindness. The common challenges include unavailability of appropriate equipment and consumables, vacant posts of ophthalmologists, unskilled ophthalmic workforce, lack of equipment maintenance, just to name a few. There is a need, and it is generally accepted, of course, there is a need for a replicable eye care model that demonstrates impact and sustainability. A bit of background about the project I'm going to talk about. So for 5 years, from 2008 till 2012, the foundation implemented a project in 10 government district hospitals. The goal of the project was to build the capacity of these district hospitals, the eye units of these district hospitals, so that they can perform high volume cataract surgeries and showcase a self-sustaining and replicable model. The 10 project locations were in the districts of Brahmanbaria, Satkhira, Jamalpur, Norail, Ghazipur, Cox's Bazar, Kishoreganj, Tangail, Nator, and Kushtia. This is what we like to call our program pyramid, and the project worked across all these levels, the community level, sub-district, district, and the national level, so as to ensure that the model it was trying to create was a very comprehensive one. In the pyramid, you can see that in the community level, it was working to create demand for eye care services. In the districts, it was working in by providing orientations to community health workers, for example, who, when they were going from house to house, could give awareness messages and identify people with vision problems and refer them to the next level, which is the sub-district level. Now, in the sub-district level, the treatments could be provided for the very basic eye conditions, like very basic eye conditions, and the identified cataract patients could be referred to the next level, which is the district level. In the district level, mainly the interventions of the project were placed, such as providing orientations to community health workers, for example, who, when they were going from house to house, could give awareness messages and identify people with vision problems and refer them to the next level, which is the sub-district level. In the district level, the supporting the infrastructure, ophthalmic equipment provision, social, human resource development, and so on. So ideally in the district levels, the cataract surgeries and other surgeries were taking place, and complicated cases were being referred to the national level in Dhaka at NIUNH, National Institute of Ophthalmology. So this is the kind of interventions that we were working on. For example, renovations in the eye unit. I think it's self-explanatory from the pictures, like the IOT, IOPD, eye operation theatre, the outpatient department, washroom even, the doctor changing room, meeting room, and conference room. You might be thinking, why the washroom? So for eye health, to ensure hygiene for the patients, it's also very important to upgrade and renovate the washrooms, because for a patient who had just undergone surgery, it's very important for him or the patient to use a clean washroom. So a lot of work went there. Separate waiting spaces in the OPD for men and women. A token system being introduced in most of the eye units so that to minimize chaos in the district hospitals. A lot of investments were made in the ophthalmic equipment area as per recommendation by the WHO, from the equipment list of the WHO recommended. Human resource development. Ophthalmologists were being supported for training on small incision cataract surgery, or SICS, at Tilganga Institute of Ophthalmology, Nepal, which is one of the best in the region. Trainings were also being provided to medical officers and nurses on relevant subjects in country and out of country also. So these trainings involved theory as well as hands-on training, which is very important in the OTs, and also observation sessions so as to motivate the eye consultant. A lot of promotional works. You can see in the picture some activities relating to empowering the communities, orientations for different categories, different communities like potters, female microcredit groups, fishermen, religious students, girls' guide, sex workers, transgenders, and so on. More pictures from community awareness sessions. Pictures are showing that leaders from indigenous groups in Cox's Bazar and Jamalpur are being provided with basic orientation on eye care here. Some examples of enter-educate communication materials which the youth could use in the youth clubs, and they could take away some important messages here and go home and share with their grandparents and so on. So during the project we noticed that there was a concerning and disproportionate gap between the uptake of eye care services between females and males, although that should not have been the case, because in Bangladesh, for example, blindness prevalence is more among women than men. So especially during International Women's Day or World Sight Day, we used to encourage more participation of women by taking the services to them through outreach eye camps and so on. Example of an outreach mobile eye camp. In the pictures you can see that patients are being transported to the venue of the outreach camp. The second picture you can see that the separate queue has been formed for the ladies. Below left you can see that an elderly lady of an ethnic origin is getting priority, getting the services in the outreach camp. And finally, those identified with cataract are taken to the district hospital to undergo the cataract surgery. Now, these outreach mobile eye camps were really generating a lot of interest in the communities, because the ophthalmic team from the district hospitals could go out there in the field and directly communicate with committee members, and it required the medical officer or a medical assistant to go out there in the field to identify cases. So a lot of involvement there and interest generated in the communities there, and it also enhanced the reputation of the local district hospital. And especially for the people located in remote locations, this was a unique opportunity, or unique opportunity to go out there and uptake eye care services. And in time we saw that people from remote locations started coming into mainstream public health services, seeking services in the district hospital because of campaigns like this. So these are some data from our first phase, and I'm saying first phase because this project was followed on by another project at a later, like for a 3-year project from 2013 to 15. So I think I'm short of time, I'll just go over. But the point here to notice is that in the OPD we saw that more females were coming in, but cataract surgeries were being taken up by less females. So we had a gap there. You can glance at it. Just to let you know, we had a proper entry and exit strategy so as to transfer the for the government, the public system to just to make the transfer more smooth for the to the government hospital. So in the second phase, the goal of the project was to deliver sustainable and quality services, and the role of the foundation here was to observe, facilitate, support and advocate, and a few refreshers training were supported, for example. So in the second phase, in the bar chart, you can see that compared to the first phase, the project budget was much low and a lot less expenditure was done, indicating that the role of the foundation was more of a support and facilitatory, observatory. So we also have the government's contribution in terms of providing space, level of effort, consumable items, and so on. Now the results, we saw in this project that 8 out of 10 eye units continued to function independently with full support from the government. In the second phase, more females than men started getting their eyes operated, which is very interesting because the communication campaign stopped, but now more females were getting going to the hospital to get their eyes operated. The quality did not deteriorate, and my indicators here are visual acuity, follow-up rate, and infection rate. Most doctors still remained motivated to perform well because of enhanced self-confidence and reputation. And the communication impact study showed that a gender-focused communication campaign left a lasting mark on communities. And in fact, in the last point, the government was so impressed with the model, it replicated this model in 2 other district hospitals, that is Kotokal and Chittagong. Data here, from the second phase, we can see that more female are going into the district hospitals to uptake services. And in conclusion, I think in very shortly I can say that it's a very much a comprehensive and replicable model, and private and public and private sector organizations can take up this model to replicate it in other districts of Bangladesh, which is very important.